So how is kidney failure treated? Well, before the 1960s in the United States, kidney failure was universally fatal. Everyone who developed kidney failure died of it. But since the 1960s, we've had two treatments available: kidney transplantation from a living or deceased donor, and dialysis, which is either in the form of hemodialysis or peritoneal dialysis. Patients may elect not to receive dialysis or transplant if they would like. That's sometimes known as conservative therapy. Physicians expect that patients will die within a few days or weeks of onset of total kidney failure if they elect not to receive therapy. As I mentioned, the treatment options for kidney failure include dialysis, and dialysis comes in two different forms. There's hemodialysis. In the top right of this slide, you can see a gentleman sitting in a bed connected to a hemodialysis machine. And then in the bottom, there is peritoneal dialysis demonstrated through those cartoons. Peritoneal dialysis is performed at home. Of course, we're here today mostly to talk about kidney transplantation as a treatment for kidney failure. In kidney transplantation, a new kidney, transplanted kidney, is placed into the pelvis in the lower part of the patient's abdomen. The diseased kidneys are usually left in place during kidney transplantation. There are more than 100,000 of the 700,000 patients with kidney failure in the United States who are listed for transplant with the United Network for Organ Sharing. About 3,500 of these reside in New England. There are approximately 19,000 kidney transplants from both living and deceased donors performed in the United States each year. Waiting time for a deceased donor kidney transplant averages 2 to 6 years in the United States and varies based on your blood type, the presence of HLA antibodies in the recipient, which can come from prior transplant or from pregnancy or from blood transfusion, as well as where you live and other factors. There are two types of kidney transplants. Kidneys come from two sources. There are deceased donors who have been declared brain dead from trauma or a stroke, or have been declared dead after their heart has stopped. The donor's family or the donor through their driver's license has agreed to donate the organs. Then there are living donor kidneys. These are donors who come forward to donate a kidney. They may be related or unrelated to the recipient. They may donate directly to the recipient or through a paired kidney exchange. Many people are interested in comparing transplantation and dialysis. It is important to understand that both of them have advantages and disadvantages. The preferred treatment for kidney failure in an individual patient depends on many factors and may change over time. Some patients do better with transplantation. Some patients do better with dialysis. The current success rate of kidney transplants at 1 year is 90 to 95%. Many patients who qualify for and receive a transplant experience higher quality of life, more energy, and fewer symptoms than they experienced when they were on dialysis. They feel they have more time for family or work, more flexibility for travel. They enjoy a less restrictive diet. They report a regained sense of control, independence, and well-being. They also enjoy, in most cases, an increased life expectancy compared to patients who remain on dialysis. On average, it's important to note that this increased life expectancy is less relevant for patients who are over the age of 60 or 70 because other issues may limit their life that's unrelated to how their kidney failure is treated. It's important always to remember that kidney transplant requires that the patient take powerful immunosuppressive medications for the entire life of the kidney transplant.
Hi, my name is Wendy Valerius. I'm one of the kidney transplant coordinators, and I'm going to talk with you about how are deceased donor kidneys distributed. In the United States, the United Network for Organ Sharing, UNOS, oversees the national distribution of all organs, including kidney transplants. The United Network for Organ Sharing has divided the United States into 11 different regions. New England is Region 1. Kidneys are primarily distributed by region, meaning that a deceased donor kidney most likely will come from an organ donor from Region 1. You can be listed for kidney transplantation in multiple regions or multiple centers within one region. 3 steps are required to receive a deceased donor kidney. 1, you must be listed and active with UNOS through a certified transplant center like Mass General Hospital. 2, you must be at the top of the list. You get to the top of the list by accumulating waiting time. Your waiting time starts either by 1, when you start dialysis. That's your start date for waiting time. Or 2, if you're not on dialysis, once your glomerular filtration rate, or GFR, is equal or less than 20, and then you're listed for kidney transplant, that will start your waiting time. The third step that's required to receive a deceased donor kidney is you must be compatible with the donor kidney. Your blood type must be compatible, and you must have a negative cross-match. Negative cross-match means a sample of your blood does not damage a sample of donor blood cells when mixed together in the lab. Positive cross-matches are due to HLA antibodies in the recipient. We call this being sensitized. Being sensitized could come from prior transplants, pregnancies, blood transfusions, or possibly infections. Having HLA antibodies or being sensitized can significantly delay transplantation. In New England, the average waiting time for a standard criteria deceased donor kidney can be anywhere between 2 and 6 years. Blood type O and blood type B have the longest waiting between 5 and 6 years. Deceased donor kidneys are assigned a Kidney Donor Profile Index, or KDPI. This will range between 1 to 100%. The KDPI predicts how long a kidney is likely to function. An example of this is if a kidney with a KDPI of 40% is likely to function longer than 60% of all deceased donor kidneys. The KDPI is calculated for each deceased donor kidney based on the age, height, weight, ethnicity, how the donor died, if the donor had a stroke, the history of high blood pressure, diabetes, or hepatitis C, and the kidney function. The KDPI is one element that describes the kidney and one element that the transplant team looks at when they decide if a kidney is a good kidney for you. Other important factors that go into the decision would include the results of a kidney biopsy, the donor anatomy, and any data if the organ was put on a preservation pump. There are different types of kidneys you may be eligible to be offered. One type kidney might be a kidney that is a KDPI that's greater than 85%. Kidneys with KDPI greater than 85% are not expected to last as long, but they could be available with a shorter waiting time. A kidney with a KDPI of less than 20% is another possible kidney. These kidneys are expected to last longer than other kidneys and are first allocated to patients who are expected to gain the most from them. A zero antigen mismatch. You may be called and told that there is a kidney offer for you that's a zero antigen mismatch. This means that the donor is a near perfect match to you. It doesn't matter how long you've been waiting on the list. You would skip to the top of the list if you were offered a zero antigen mismatch kidney. This is like getting one of these kidneys is really, really good luck. En-bloc kidney. If your body size is small and you meet other criteria, you might be eligible to receive small kidneys, which would be adequate for you and will grow over time. Hepatitis C kidneys. If you have hepatitis C, you can consent to receive a kidney from a donor who has hepatitis C. Because not everybody can receive these types of kidneys, your waiting time will be shorter. Increased risk. If you agree, you will likely wait shorter if you receive a kidney from a donor who has been labeled increased risk. Donors are labeled increased risk if they have behaviors that have put them at increased risk for having the transmission of HIV, hepatitis B, or hepatitis C virus. An example of this may be a person who's died that's now an organ donor who has a history of IV drug use. In these organ donors, the tests that they do may be all negative, but the donor may be in the window period in which the viral infection is present, but the tests are negative. This is called a false negative. In recent years, 30+% of the New England organ donors have actually been increased risk. All donors are screened for diseases, viruses, and cancers. Unfortunately, the testing is not 100% accurate. We already talked about this, but for instance, a donor may be in the window period for an infection such that the virus is present but the testing is negative. The donor may have a cancer that is undiagnosed that could be transmitted to the recipient by the new kidney. Some viruses, like cytomegalovirus, CMV, and Epstein-Barr virus, EBV, are present in 50 to 90% of the population and are frequently transmitted with transplant. In general, the transplant team has effective ways of dealing with these viruses. Overall, the transplant team will always discuss specific organ donor options with you at the time you are offered a kidney. You always have the right to decide that that kidney is not the right one for you and to decline that kidney offer. This will not cause penalty and disrupt where you are on the kidney transplant list. Please know that the transplant team is committed to ensure that they offer you the best kidney that matches you the most and will work for as long as possible.
Hi, my name is Laura Cornicini. I'm the Kidney Transplant Coordinator. We're going to discuss the live donor kidney transplant. In live donor kidney transplantation, a person donates one of his or her kidneys to a recipient. The donor does not have to be related to the recipient, but must volunteer and cannot be paid or receive other valuable compensation. Anyone who is willing and is in excellent health is a potential donor. Benefits of living kidney transplantation. The recipient can avoid dialysis or be on dialysis for a shorter time than waiting for a deceased donor. Kidney transplants from living donors are more likely to function immediately, experience a lower risk of rejection, last longer with half-life of about 4 to 16 years versus 10 to 12, are performed as elective surgery rather than urgent surgery. Most donors report being very happy with their decision to donate. The challenges of a living kidney transplantation. The recipient or family friends must identify the living donor, and the donor must undergo kidney donation surgery and live with one kidney. Our criteria for a living kidney donor. The living donor must be more than 18 years old, donating voluntarily, in good overall physical and mental health, and free from the following: diabetes, obesity defined by a BMI less than 32 to 35, free from active drug or alcohol abuse, any significant medical conditions which might impact donation risks such as heart, lung, or liver disease, bleeding or clotting disorders, or any recent cancers except some skin cancers. They must be free from HIV, hepatitis B and C, other infections and behaviors that increase risk of these infections. They must be free from psychiatric conditions such as depression or anxiety, requiring treatment or at risk for significant recurrence. They should be free of kidney stones and high blood pressure, may also be exclusions, and they should stop smoking and using oral contraceptives for 4 to 8 weeks, respectively. For direct donation, the donor blood type must be compatible with the recipient. Blood tests determine the donor and recipient blood type. Donations can occur as follows. O is the universal donor and can donate to all blood types. A can donate to A or AB, B can donate to B or AB, and AB can donate to AB. The positive or negative on your blood type does not matter for kidney transplantation. For direct donation, the recipient and donor must have a negative cross-match. A negative cross-match means that a sample of the recipient's blood does not damage a sample of donor blood cells when they are mixed together in the lab. Positive cross-matches are due to HLA antibodies, which come from prior transplants, pregnancies, blood transfusions, or possibly infections. Other options for donor-recipient pairs when direct donation is not possible: kidney paired donation or exchange. This is when the live donor donates to someone else and the recipient receives a live kidney from a donor who is compatible. And desensitization. This is the removal of blood group or HLA antibodies from the recipient to allow the transplant to occur. This is more rigorous for recipient and associated with a higher risk of rejection.